So recall that your pancreas, located next to the duodenum and the greater curvature of the stomach, it certainly has lots of exocrine functions that we'll talk about when we get to the digestive system. We're interested in the endocrine functions. When we look at the pancreas, we find that there are collections of cells spread throughout the pancreas in these areas that we call the islets of Langerhans. And so here's this islet of Langerhans. In each islet, there are two major types of cells, alpha cells and beta cells. Again, they just used letters of the Greek alphabet. Okay? So they were just using letters of the Greek alphabet. It turns out that the alpha cells produce a hormone called glucagon. You know about from anatomy, but the general population probably has not heard of this hormone, glucagon. Glucagon is released when blood glucose levels drop. Okay? So when blood glucose levels drop, the alpha cells are stimulated to release glucagon. The way that I always remembered it, folks, is I said to myself, where has the glucose gone? All right? So this is the hormone of fasting. When you do not have enough glucose in the blood, alpha cells will be stimulated to raise the blood glucose levels up by releasing glucagon. It turns out that your brain requires glucose to function. We need glucose for lots of tissues, but the brain is really dependent almost solely on blood glucose levels. So if the blood glucose levels start to drop, we've got to bring those blood glucose levels back up. Fortunately for us, in your liver and in your skeletal muscles, you have a stored form of glucose that we call glycogen. Okay? So glycogen is really just a whole bunch of glucose molecules that have been hooked together. Kind of like starch. It really is the body's own starch in your liver and in your skeletal muscles. So you skipped lunch maybe today, right? Gosh. You had to go to the lecture, you weren't quite ready, you got ready, came, blood glucose levels are falling. But in order to keep your brain functioning, you've got to bring those blood glucose levels back up. The alpha cells are causing the glycogen in those stored tissue, the liver and the skeletal muscles, to break down and release glucose. So we call that breakdown of glycogen, cleverly named, glycogenolysis. The lysis of glycogen, right? Breaking down of glycogen to release glucose. The hormone that the general public has heard of, that you know about, of course, is insulin, and it's going to be released from the beta cells. It's going to be released from beta cells. So you just couldn't stand it. You got to school. You had to get something, right, because you were starving. So you went and bought a candy bar. You ate the candy bar. All of a sudden, the blood glucose levels come up. And in order to move the glucose into the cells, because glucose is a relatively large polar molecule, it's got to be helped, right? Facilitated diffusion. Your beta cells will release insulin, and insulin is able to bring transporters in your cells. And so this is going to work here. Showed my link. Hey, what's wrong with my link? All right. Link, there it is. So in your liver, in your skeletal muscle cells, and in your adipose cells, when insulin is released, it causes these glucose transporters to come to the surface of the cell and join with the cell membrane so that glucose can then be moved by facilitated diffusion into liver, adipose cells, and skeletal muscle cells. It increases the movement 20 times, right? And so without insulin, you're really not going to move glucose in. Hardly at all, right? You really need that insulin hormone to do that. Additionally, and besides moving glucose in, it causes the glucose, once it's inside the cells, to turn into glycogen. And so they came up with a clever name for the formation of glycogen. They call it glycogenesis. Genesis is the beginning, right? The making. So glycogenesis is the making of glycogen. Be careful, right? That word looks pretty similar to that word, but glycogenolysis has lysis in it, right? Glycogenesis means the making of glycogen. So it causes the glycogen to turn, or the glucose to turn into glycogen. It decreases the use of triglycerides. Okay, so it's going to stop the use of triglycerides in the body. You don't need to be using triglycerides when blood glucose levels are up. And it stimulates protein synthesis. Stimulates protein synthesis. Years ago, I had a bodybuilder in this class, and so we went through this and we talked about the stimulates protein synthesis, and the bodybuilder raised his hand and he said, well, how much insulin should you take? And I said, well, you know, that's when you have diabetes, the doctor will help you in terms of, no, we're bodybuilding. Bodybuilders sometimes inject themselves with insulin to increase protein synthesis. Unbelievable, right? Trying to increase the size of their muscles by injecting themselves with insulin, which if you take too much insulin, you can imagine what's going to happen to blood glucose levels, right? They'll plummet.
Call 911.
You need to call 911. Well, if they're still conscious, we'll get to that, but we can give them sugar, right? But at any rate, well, the obvious abnormality here is diabetes mellitus. Diabetes means excessive urine production. It means a running through, like a siphon. Mellitus means honey flavor. There's another type of diabetes, a type of diabetes that we call diabetes insipidus. Huh? So there's a diabetes insipidus. Insipidus means no flavor. Physicians didn't always have fancy pieces of equipment or glucose testers to check blood glucose levels. So before they had fancy ways of checking blood glucose levels or checking the urine, they would smell and taste the urine to see if it tasted sweet. If it tastes sweet, like honey, they had diabetes mellitus. If it had no flavor, they had diabetes insipidus. Diabetes insipidus is caused by a lack of antidiuretic hormone. Does that make sense? Diabetes insipidus would be caused by a lack of antidiuretic hormone. So large amounts of urine being produced that doesn't have any flavor because they are lacking the ability to produce antidiuretic hormone. I have a friend of my goddaughters who developed diabetes insipidus. She started urinating frequently, having to get up during the night to urinate lots, developed very high thirst. Of course, the first thing they thought was that perhaps she had developed diabetes mellitus. They did all the glucose tests, urine tests, no diabetes mellitus, but she had developed diabetes insipidus. They couldn't link this directly to it, but she had also been a soccer player for many years. And so there was some suspicion that by heading the ball all the time that she'd actually damaged her hypothalamus and had now developed diabetes insipidus. So she is now on antidiuretic hormone therapy, right, to treat diabetes insipidus. Unlike diabetes mellitus, where there is a sweet taste to the urine. Along with being able to taste urine, smell urine, one of the things that doctors learned many years ago, right, so we're talking hundreds of years ago, was that if a patient presented with weight loss and high thirst, they would look at their shoes to see if there were white spots on their shoes. Because, believe it or not, folks, a couple hundred years ago, They didn't have service stations and fast food places where you could go use the restroom. Instead, people just peed wherever they were, right? So on the street, and on the corner, or whatever. And when they peed, the urine would splatter, it would get on their shoes, and if it dried, the sugar crystals would show up on the shoes, and they could recognize that they had diabetes mellitus. We'll talk more about diabetes mellitus on Wednesday. Welcome back, folks. Good to see you. Yes, we said located next to the greater curvature of the stomach and the duodenum. Two types of cells, alpha cells and beta cells, two different types of hormones. Alpha cells producing glucagon. Where has the glucose gone? It's going to cause glycogenesis, right? So you're going to break down the glycogen to supply the body with glucose. The beta cells, on the other hand, are going to produce insulin, and they're going to produce insulin when we have a bunch of feasting that has occurred, right? So glucagon, the hormone fasting, insulin, the hormone of feasting. You've increased your carbohydrate input, blood glucose levels go up. What are we going to do to move the glucose in? We've got to have beta cells to release insulin so that it brings those transporters to the surface of the liver cells, skeletal muscle cells, and adipose cells, which will allow glucose then to move in. And we just barely started talking about diabetes mellitus. We contrasted it with diabetes insipidus, right? Because diabetes mellitus, there's a large amount of urine produced, but it's sweet because there's increased glucose in the urine. We're going to find when we get to the urinary system that it really has to do with the fact that you overload the kidneys with glucose, they can't pull the glucose back fast enough. And so it ends up being dumped into the urine because of the high blood glucose levels. It turns out that really there are two very different types of diabetes. The only thing they have in common really is that they have high blood glucose levels. They're very different diseases, type 1 and type 2. Type 1 is sometimes called juvenile onset because it usually occurs in individuals under the age of 25. And type 2, usually called adult onset. There are exceptions, so those are another names, juvenile and adult. Type 1, type 2. Let's look at type 1. So again, commonly found in young people under the age of 25. It is an autoimmune disease. So in this disease, the immune system becomes sensitized. We still don't really know why. And when it becomes sensitized, it produces antibodies to the beta cells. We can measure those antibody levels. The beta cells are under attack by the immune system and will be destroyed. When the beta cells are destroyed, the individual can no longer produce insulin. Blood glucose levels will rise, and certainly they'll have glucose in their urine. But the really serious part is that if you're not able to use glucose, your body then has to work using the fats that you have stored as energy. So if you started fasting, right, said, okay, I'm going to go on a 24-hour fast, you would certainly use up all the glucose that you have available, and then you know you would be burning fats. Well, when you start breaking down fats in large quantities, the fats become something called ketones. And we're going to look at this when we get to the metabolism. Ketones are acids. And so these individuals develop ketoacidosis. Okay? They develop ketoacidosis. And ketoacidosis will result in death. Recall when we talked about enzymes, we said there's a very narrow range where the enzymes are able to function. Too high a pH, too low a pH, your enzymes can't function. And if we drift out of that normal pH range, the brain can't function and you will die. Typically when this is occurring, when the person has ketoacidosis, they will first go into a bit of a stupor and they may act drunk. These ketones smell like acetone. So acetone, you probably are familiar with, you didn't know you are, it's commonly found in nail polish remover. So it has kind of an alcohol, fruity flavor. Yes?
Sorry, you said that the ketoacidosis comes from the fasting of large amounts of fat versus
That you're breaking the fats down.
and that turns into the
It turns into ketones. Because the body's trying to supply energy through an alternative way by breaking down fats. So the ketones have kind of an alcohol smell. The person starts to go into a stupor, and so a classic example would be police are called because somebody's staggering around on the street or laying on the street and acting like they're drunk. The policeman comes, smells their breath, and say, "Aha, a drunk. I'm going to haul them down and put them in jail because they're drunk." And the person wakes up dead, right? Because they shouldn't have been hauled down to the police station. They should have been taken to the hospital because they were experiencing ketoacidosis. Yes?
But this commonly happens in children. So if you saw these symptoms in a child,
No.
it'd be able to
So it begins in childhood, but this disease never goes away. And so the person might be 50 years old and have ketoacidosis, right? So type 1 diabetes begins in childhood, but lasts a lifetime. Yes?
So does it change over to type 2 once they reach 70?
No. It's a completely different disease. We'll get to type 2 in a minute. So up until 1921, and I don't care that you know 1921, but up until 1921, when a child was diagnosed with type 1 diabetes, their average lifespan from time of diagnosis to death was about 6 months. There was nothing they could do, right? So they developed ketoacidosis. Gradually, as the beta cells were being destroyed, and eventually they died from the ketoacidosis. In 1921, a couple of Canadian physiologists, you don't need to know their names, Banting and Best, discovered insulin. They worked with dogs. I know it's horrible. They experimented on dogs. I feel horrible about it, right? They experimented on dogs. They removed the pancreas from dogs and said, look, the dog not only couldn't digest food, but they developed diabetes. They then went in and they injected wax into the pancreatic duct and said, okay, let's see if we stop up this duct, if the animal will get diabetes. They didn't get diabetes. Why not?
Because insulin is
It's an endocrine gland that they're talking, right? Remember, endocrine glands are ductless. So it was really the beta cells, right, that were in the islets of Langerhans. So they eventually isolated insulin, and once they isolated insulin, they were able to get insulin from beef and pork. Horrible. They kill those animals, and then they would get the insulin from them and save people's lives. Terrible thing to do. But they were able to get insulin from beef and pork. Once they did that, they were able to keep people alive for relatively normal length of life. Now, it's not cured, it's just treated. And we'll look at some of the side effects of long-term high blood glucose levels in a few minutes. Now, 25 years ago, Genentech, up in the Bay Area, isolated the human gene for insulin, and they started putting that gene into bacteria, and so then new diabetics, when they start on insulin, are given human insulin rather than pork or beef insulin, which is it works much better, and they don't tend to develop any immune response to the fact that it's from another animal. Okay, so that's ketoacidosis. If a person receives too much insulin, they can go into insulin shock. So if you get too much insulin, blood glucose levels are going to drop dramatically. And if blood glucose levels drop dramatically, remember the brain is dependent upon blood glucose levels, the person will go into insulin shock and may die. Hopefully somewhere in a first aid course they told you that if you come across a person that you know is a diabetic, ideally they're wearing a bracelet or a necklace to indicate they're diabetic, and if they're starting to have problems functioning, they still have to be conscious, you give them sugar and transport to the hospital. All right, so if they're in insulin shock and you give them sugar, you'll start to see almost an immediate recovery. If they're developing ketoacidosis and you give them sugar, the ketoacidosis is not being caused by the sugar, right? It's being caused by the fact that they can't transport glucose into their cells, so you haven't hurt them. On the other hand, if they're in insulin shock and you say, oh, I know what they need more insulin, and you give them more insulin, you've killed them, right? So, if they're conscious, sugar and transport to the hospital. All right, so what about type 2 diabetes, this other type of diabetes? The only thing that it has in common with type 1 is that they have high blood glucose levels. It is not an autoimmune disease. In type 2 diabetes, usually in adults, we'll find that, I'll tell you an exception to that here in a minute, but usually in adults, the problem isn't that their beta cells have stopped functioning. The problem is that their adipose cells, liver cells, and skeletal muscle cells have quit responding to the insulin. We call it insulin resistance. Sometimes they'll call it insulin tolerance. But insulin resistance, insulin tolerance, the cells don't respond to the insulin. So their beta cells can still be cranking out insulin, their cells won't respond. Now we know that there is a strong genetic component to type 2 diabetes. There's some genetic component to type 1, but there's a strong component to type 2. If you have a mother or father that has type 2 diabetes, you have a greatly increased risk of developing type 2 diabetes. We know that if you are overweight, you have an increased risk of developing type 2 diabetes. And that's not the genetic part. Yes? Here.
Also gestational.
Exactly right. So if you had gestational diabetes, that is, you developed diabetes when you were pregnant, we know there's increased risk of developing type 2 diabetes. Yes?
My son's father, he's type 2 diabetic, and most of his family is also diabetic, but they all got it after a certain age. The reason that he had it is because he was alcoholic for a long time. Does that increase the...
You know, I have to say, somebody knows. I don't know if there's a link between alcoholism and type 2 diabetes, but it wouldn't surprise me because the body essentially treats alcohol as sugar.
Right.
And so we know that in type 2 diabetes, when the person is constantly exposed to increased blood glucose levels and has this tolerance or resistance to insulin, that it tends to worsen.
Well, my main question is because my son, say he monitors his diet and he doesn't become alcoholic, and he's still at a high risk.
Because of the genetic component. So, more than what we need to get off to in this class, folks, but when they look at genetic diseases, one of the best things that they can do is they look for something that they call concordance between identical twins. So you take two identical twins and you check if one identical twin has the disease, then does the other identical twin have the disease, right? And if it's a genetic component, you would expect to see a strong relationship. So when they look at type 2 diabetes, they find very strong concordance between the two identical twins. When they look at type 1, it's not as strong. There's not as strong a link. Yes?
How do they test for type 1 diabetes to determine whether someone has that autoimmune disease versus just having low blood
So the question is how they type. I mean, one of the reasons that we can tell is certainly, well, I'm going to look at a list here in a minute, but type 1 diabetes comes on relatively strong, quickly, but we can actually check antibody titers. So we check for the titer, meaning the level of the antibodies in the blood. We can check antibody titers to see if the person has produced these antibodies. Go just a little bit more on the genetic thing. If you go down into New Mexico, there are Native Americans down there called the Pima Indians. They have very close relatives, genetic relatives, that live in Mexico. The Pima Indians in the United States have a very high incidence of type 2 diabetes. If you go check their, quote, cousins in Mexico, we find hardly any type 2 diabetes, even though genetically they're very similar. What's the difference?
Diet.
Diet and exercise. So the Pima Indians in Mexico are still plowing their own fields, grinding their own corn. They don't have the golden arches, okay? And so they don't have ready availability of the fast foods, high-fat diet. They're also very active. So I said up here that generally it's found in in adults, but then I said, surprising increase in children. When I first started teaching here in 1978, we never talked about type 2 diabetes in children. It just was really unknown. It's surprisingly high, not as high as type 1, but surprisingly high in young children now. And we know that it's due to high-fat diets and lack of exercise. Target age for McDonald's to make sure that kids recognize the golden arches. Anybody know?
3.
Age 3. McDonald's wants the children to recognize the golden arches by age 3. Mommy, Daddy, McDonald's, right? Toys in the food, slides, right? Playground. Nathan knew it by the time he was 3. He knew this is where you go. You get a little toy in the package and you get, right? And so very quickly we start to load on the pounds, and we know that with increased weight, the body becomes less able to use insulin. We'll talk about why a little bit more when we get to the next little heading that I have here. But, well, actually, so there it is. Adipokines affect sensitivity. So it turns out that there are hormones that are being produced by your adipose cells. We call them adipokines. I'll tell you the name of one of them. You don't need to know it. One of them is leptin. There are others. And we know that as those adipose cells fill up with fat, they produce more of these hormones, the adipokines, and they tell the body, we don't need to be responding to the insulin because we have enough adipose. It's a negative feedback loop. Do you see it? Right? I'm a nice plump adipose cell. I don't need any more storage of fat. Let's make the cell less resistant or less sensitive, to insulin so that I don't have more glucose coming in to turn into more fat. So it didn't used to occur at all. We know it's occurring now, right, in young children. So type 2 diabetics are generally obese. They make up more than 90% of all the diabetics. So if you know a diabetic, chances are great it's a type 2 diabetic, not a type 1. You'll know maybe a type 1 too, but right, 90% of or more of diabetics are type 2. We can give them oral medications. The oral medications do two things. They increase the sensitivity of the cells to the insulin, and they can also stimulate the beta cells to produce more insulin. Over time, as those beta cells keep trying to respond to the high blood glucose levels, oftentimes the beta cells actually kind of burn out and they'll stop working. So they may become eventually dependent upon insulin in order to function. We know that if you take a type 2 diabetic and you change their exercise, you get them to lower weight, and to change their diet, that oftentimes that type 2 diabetes can be reversed. Anecdotally, a person that used to work in our audiovisual department, been retired now for a good 10 years, while he was still working here, felt horrible over a weekend. He just told his wife, I don't feel good, I need to go to the emergency room. They went to the emergency room, they checked his blood glucose levels. His blood glucose levels were over 800. Now we expect blood glucose levels to be right around 100, right? He was diagnosed with type 2 diabetes. He was overweight, didn't exercise. So the doctor put him on oral medication, and his wife said, you're not going to die from type 2 diabetes. And so they went both together on an exercise regimen. She completely changed their diet. He lost 35 pounds. He was able to go off his oral medication. I ran into him a couple of years ago, actually, at Costco in Salinas. And I said, Bill, how you doing? He says, oh, God. He says, I feel great. I'm doing all these things. But he says, I sure would like a cheeseburger. Yes?
What's the difference in gestational diabetes, and why do they say women who get it can later on in life develop?
Yeah. So a little bit beyond the scope of this course, but sometimes when women are pregnant, they get gestational diabetes. It's pretty common for blood glucose levels to go up. It's very common for blood glucose levels to go up when a woman's pregnant because that fetus needs more food, right? So the fetus actually produces a protein hormone that increases blood glucose levels. Now, for some reason, some women over-respond and develop very high blood glucose levels. Not well understood. But these women, same women, we know by statistics that once they've had gestational diabetes, later in life they're at increased risk relative to the general population. Not well understood.
Nothing to do with their family history?
Not necessarily genetic, so something to do with the fetal hormone that was produced, and we don't know. Not well understood. Okay, so here's a table that we could go through and hit some of the highlights of some of this. Some of it I've hit already, but it'll remind me of a couple more things that I want to tell you. So age at onset, usually under 20 or 25 for type 1, over 40 usually for adult. Proportion of diabetics, less than 10% for type 1, greater than 90 for type 2. Seasonal trend, this is pretty interesting. We know that type 1 diabetics tend to develop diabetes in fall or winter. That's pretty peculiar, which has led to a hypothesis that perhaps the stimulus for the autoimmune response may be a virus. And they actually have a virus that they're interested in, you don't need to know it, called the Coxsackie virus, but they haven't shown that that virus causes the type. So the takeaway message isn't that the type 1 diabetes is caused by a virus, it's just there seems to be some link, right? We'll talk more about autoimmune diseases when we get to the immune system, but typically there is some environmental insult, some stimulus that stimulates the immune system, and once that occurs, the body responds to that by making antibodies to the antigen, but sometimes there is a cross reaction to our own tissues. Anyway, interesting.
Can I ask you a question
Yes.
about that? Is that also found in the tropics?
I don't know how widespread Coxsackie virus is. I'd have to look that one up. I don't know.
Or what about type 1 diabetes?
Oh, type 1, yeah, it's found worldwide. It was found in the ancient Egyptians. They knew about type 1 diabetes. So you can read about it in the hieroglyphics. It's been around forever. But type 2 diabetes is much more prevalent than it ever used to be, right? Because we have golden arches. Appearance of symptoms, acute or subacute, meaning they come on quickly in type 1. Slow in type 2. Metabolic ketoacidosis is frequent in type 1, rare in type 2, because, right, again, the type 1 diabetics have been just cut off from their insulin, and so they're going to develop ketoacidosis. It's been a very gradual change that's occurring in type 2. Obesity onset, common in type 1, or type 2, excuse me, uncommon in type 1. Beta cells, of course, will be decreased in type 1, variable in type 2. Insulin, of course, decreased in type 1, variable in type 2, because, right, if those beta cells are burned out. Inflammatory cells in the islets, initially present, meaning, right, there's inflammation in those islets of Langerhans. Not going to be common. It's not going to happen in type 2 because it's not an autoimmune disease. We know now that when the symptoms first start to appear, as I mentioned earlier, you can test the antibody titers in these young children and find that they are producing antibodies to their beta cells in their pancreas. We know that we could actually stop that by giving them drugs to stop their immune system from functioning, immunosuppressive drugs, but right now that treatment is worse than actually developing type 1, right? So essentially it's like they've had an organ transplant. Family history, uncommon in type 1, quite common in type 2, I said that already. An HLA association, it turns out that there is a particular antigen that we can check for. We'll talk about this a little bit when we get to the immune system, called the human leukocyte antigen, that's common in type 1, not in type 2. And then antibodies, as we said already, common in type 1. They're not going to be present in type 2. Before we get to the advancements, I mentioned this already, but we can treat diabetes, we don't cure it. And so we know that long-term effects of high blood glucose levels have detrimental effects on the body in numerous areas. Number one cause of blindness in the United States, diabetes. Number one cause of amputations, diabetes, because it affects both the circulation, the blood flow to an area, and it affects the ability to feel that tissues are damaged, what we call, you don't need to know the term, but neuropathy. So a classic thing that happens in a diabetic is either type 1 or type 2 is they develop a sore on their foot. They don't feel the sore, it develops gangrene, and they end up having to have their foot amputated. Renal disease, common in diabetics, both type 1 and type 2. All these things we know are linked to high blood glucose levels, and that's why it's so critical that diabetics maintain normal blood glucose levels. Now, years ago, the only way the diabetic could get their blood glucose levels tested was to go to the doctor's office. Now you see in every drugstore, everywhere, right? They can go and buy glucose monitors, so they're very, very common. They even now have nice little portable monitors that essentially like a wristwatch that can measure the glucose levels electrically by looking at the interstitial fluid. Yaren?
I have a girlfriend who has a machine attached to her stomach. What?
Yeah, so Yaren's asking about an insulin pump, which is up there on my terms of advancement. So a diabetic has to give themselves, a type 1 particularly, right, needs to get insulin. And so when their blood glucose levels go up, they need to get insulin. And of course that, in the past, has always meant, all right, go find some place where you can go in the restroom and give yourself a shot. They have insulin pumps that they wear with a very small tube and a very thin needle that they can automatically give themselves insulin shots. And they can change that level by adjusting the pump so that they don't have to go find a place where they can do the injection. They also have nice little injectable pens that they can adjust the dosage and gives themselves the shot very easily without, right? The whole thing is, okay, now where do I go to give myself a shot? Right? How do I test my blood glucose levels? Ideally, what we would like to do is close the loop. Remember, I used that term on Monday. We know we can give them a pump now. We know we have electric glucose testers. They are working on connecting the two. So they have some experimental versions that are available where the electric glucose tester is connected to the pump. And so now when their blood glucose levels go up, insulin would be released. When glucose levels go down, insulin would not be released. So in a sense, right, you've kind of made an artificial pancreas by closing the loop, right, having negative feedback.
It makes a noise when it goes.
It's a pump.
I didn't even know. It's like, I'm like, what's that? She's like, I think something insulin. I'm like, oh.
Inhalants, the FDA approved an insulin inhalant in 2006. It wasn't widely used, and so the maker actually withdrew it, but it was an inhalant that they could put into their noses. They didn't actually have to give themselves shots. They are working on oral insulin. Insulin is a protein, and so the problem is, of course, if you eat a protein, the stomach says, digest, right? So they are working on encapsulating the insulin so that it can be absorbed without being digested. Artificial pancreas, I said already, linked to the electric glucose testers. Transplants would be ideal. They have had success with transplanting beta cells from the pancreas. Normally they don't want to do this unless the person has already had some other organ transplant, because if you receive a transplant, you have to be on immunosuppressive therapy. We're going to talk more about that when we get to the immune system. And then, wouldn't gene therapy be nice, right? And so if the person has these genes that cause the person to get diabetes in the first place, wouldn't it be nice to be able to change those genes? Yes?
So
Alex?
with type 2 diabetes, it's manageable with correct diet and exercise. So in essence, the advancements would only be like extremely effective for people that have
So
type 1
for type 1. But you know, if the person's unable to manage their type 2 diabetes, then what do? Right? So you have oral medications. It's not that uncommon for them to have had type 2 diabetes so severely that they burn out those beta cells and now they're insulin dependent. But these would be advancements for that. Yes?
Transplants, there are also other transplants other than pancreatic transplants are also related to diabetes, because when you have a transplant, usually you're taking immunosuppressant drugs, and largely those are glucocorticoids. And
glucose levels go up.
yeah, so many transplant patients are also dealing with diabetes
Because of high blood pressure.
you know, and they have to stay on these things really long term.
You're correct, Ann.
And also, Stress is, of course, sets off lots of glucocorticoids. So one of the things that are closely related to diabetes is living a stressful life.
I haven't seen those studies. They're probably out there, but I haven't seen them in terms of stress and type 2. I'd have to look for those.
But you know about stress and glucocorticoids,
yes,
and
but I
so
haven't seen the link to type 2 diabetes, but it may be there. All right, so I know I spent quite a bit of time on diabetes, but I suspect everybody in this room knows somebody that's a diabetic. It's right, it's important that you have an understanding of that disease. Your pineal gland. Your pineal gland is located up there in the midbrain region, near the corpora quadrigemina. Okay? That's where your pineal gland is. In lower animals that don't have the developed skulls like we do, the pineal gland is actually quite near the surface of their skull, and so direct light affects their pineal gland. Our pineal gland, of course, is buried much more deeply inside our brain, as is in, of course, all mammals. Nevertheless, we know that the pineal gland responds to light. It's not getting light here, but it responds to light in our environment. We'll talk more about that in a minute. We know that the pineal gland produces a hormone called melatonin, not to be confused with melanocyte-stimulating hormone, right? Very different. So it produces a hormone called melatonin. And we know that in many mammals, the levels of melatonin are linked to what we call seasonal breeding. Right? So you probably know from somewhere that there are certain seasons where the deer mate, or the elk mate, or sheep, or cattle, whatever it may be. So how is it that they are tying their mating to the seasons? It's dependent upon how much light they are receiving. We know that when we're exposed to more light, melatonin levels drop. When you're exposed to less light, melatonin levels increase. So at night, our melatonin levels go up. During the day, our melatonin levels go down. And of course, as the seasons change, levels of light change. In humans, melatonin is not linked to seasonal breeding. Humans will breed anytime. Right? So it's not a factor there. We do know that in humans, melatonin's involved in sleep-wake cycles. So how much time you're going to be sleeping versus awake. So the levels of melatonin go up at night, which makes you sleepy. They go down during the day, so you're not sleepy. Erin?
Erin, so that hormone, is it supposed to just relax you and make you feel really calm?
Oh, no, it just tends to make you sleepy. Right? So not necessarily calm, but sleepy. Some people use it to help with jet lag. The United States is one of the few countries where you can actually walk in and buy it over the counter. In Europe, it's by prescription.
We sell at Trader Joe's.
Yeah, so,
people buy 20 to 25.
I have to say, this was a long time ago. I went to Korea to watch my brother wrestle in the Olympics. I arrived in Korea. It was nighttime, evening, really. I had a nice meal, went to bed, and woke up about midnight, and it was just about noon here in Monterey. And I spent the rest of the night watching Korean television, which was not very interesting to me. Because I was wide awake. It was like it was being in Monterey, right? So I had severe jet lag. I would have to say probably if I did that kind of a trip again, I probably would take some melatonin with me. On the other hand, when people routinely, as Erin is saying, buy melatonin by the truckload and take it home and take it, you've been in this class long enough to know that there are negative feedback cycles. So if you start taking melatonin, what's your pineal gland going to say? Stop making melatonin. I don't need to make it. Yes?
Why is it a prescription? In other countries it seems so benign.
Yeah, but it's not that benign. That's why it's prescription. It's a hormone, right? And so that's why it's prescription. Yes?
So is it a protein? I mean, you just said from the insulin, oral insulins, they're digested.
Yeah, melatonin, gosh, you know what? I should know this. I'm almost certain it's a polypeptide, but it doesn't get digested. It's not going to be a steroid. I have to look that one up. I should know, but off the top of my head, I can't think of it. So I would caution against using melatonin willy-nilly over the counter, right? maybe for if you're having severe problems with insomnia or something, but short of that, I wouldn't take it just because it's there. Yes?
Could it be reversed if you stop taking melatonin?
Sure, right, over a period of time, right? So that's how negative feedback systems work. Recall that when we were looking at the eye, we said that the ganglia cells of the retina produced contained a light-sensitive opsin that we called melanopsin, right? Remember melanopsin? So we know that part of the way that the pineal gland is being stimulated by light is by the melanopsin that's in your eyes. An exciting experiment was done about 10 years ago, exciting to me anyway, I thought. They took fiber optic tubes and they put them on the back of people's legs, taped them all up so that the people couldn't see them, and then they measured their melatonin levels depending upon how much light they were giving them through their skin on their legs, and they found that they were able to change the melatonin levels by changing the amount of light on their skin. So your skin apparently is also working as some sort of giant light receptor organ to affect your melatonin levels. Melatonin levels have been linked to a condition that we call SAD, seasonal affective disorder, right? So you've heard of people becoming depressed, particularly in the northern climes when they have less exposure to light, right? And so we know that there is some link to melatonin and the SAD syndrome. Your thymus. Okay, your thymus.
What about puberty?
Oh, that's up there, huh? I didn't mention it. Thank you. There is some link to onset of puberty with the pineal gland. Not a strong link, but some link. We know that a tumor in the pineal gland can bring early onset of puberty. So you can have 3-year-olds that go into puberty from a tumor that's in the pineal gland. They're still trying to figure out exactly what the triggers are for beginning puberty. It's really an interesting phenomenon if you think about it, right? I mean, what triggers all of a sudden the body to start producing FSH and LH, right? So all of a sudden they start coming from the anterior pituitary, which started puberty. I remember in 3rd grade, 4th grade, I hung out with all my buddies. We played a lot of kickball and tetherball. The girls were over there playing hopscotch. They had cooties, right? But by 5th grade, I thought hopscotch might be a good game. And so what happened, right? I mean, all of a sudden, something changes, and you start to go through puberty. So there may be some link to puberty onset and the pineal gland, not well understood, other than we know that a tumor in this area can bring on early onset. Yeah.
Do you know anything about the calcification of the pineal gland?
Pineal gland can calcify. I don't know much about it. Right? I know that happens, but I don't know much about it. Certainly then it isn't going to produce the melatonin. So, you know, calcification is a common way for the body to kind of respond to inflammation and to stop an organ from functioning. But I have to say, I'm not up on it. All right, your thymus, a strawberry-sized gland located anterior to the heart and superior to the heart, quite large in children. By the time people get to be my age, there's not much left of it, right? So it gradually atrophies over time. We know that the thymus produces a hormone called thymosin. That is an important hormone for stimulation of the normal immune function. So if you remove the thymus gland from an animal, a young animal, their immune system will not develop normally. There are some studies that would suggest that one of the reasons that older people succumb to more diseases is because their thymus is no longer functioning the way that it did when they were younger. Lots of experiments being done with thymosin, trying to stimulate immune responses, early stages still.
Is that because thymoma is cancer?
Thymoma would be a cancer of the thymus. Yeah, so oma is what they add to any word. That's where the cancer comes from. Gonads, we're going to talk about when we get to the reproductive system. Ovaries, testes, producing, right? Testes, testosterone, ovaries, estrogens, and progesterone. And then finally, a group of hormone-like chemicals that we call the autocrines. Okay? The autocrines. Now remember, at the start of this lecture on endocrine system, we said in order to be a hormone, it had to be produced by specialized cells and target specialized cells. The problem with autocrines is virtually every cell produces them. So we can't really call them hormones, right? So they're widely found in the body, but they act like hormones, and so here's as good a place as any to talk about them. They are derived from a common chemical called arachidonic acid. This thought would be a great name for a band, right? Arachidonics.
Does it have like spidery legs on it?
Yeah, there you go. That's good. They looked at these chemicals and they thought it looked like it had spidery legs. So it turns out, they're trying to show in this diagram, here's this precursor, this arachidonic acid, and it's worked on by 2 different enzymes and changed into 2 different groups of chemicals. So one enzyme is something called cyclooxygenase, and cyclooxygenase can change arachidonic acid into the prostaglandins. Into prostaglandins, which we mentioned briefly before. On the other side of this chart, it's showing you that arachidonic acid can be worked on by an enzyme called lipooxygenase. And if it's worked on by lipooxygenase, it turns into the leukotrienes, which I briefly mentioned before. We know the leukotrienes are involved in inflammation. They're also involved in things like bronchoconstriction, vasoconstriction. The prostaglandins have a wide variety of activities. Tell them I'm busy. Right? The prostaglandins, look at some of these functions up here. We're not going to go through all these, but look at, so here's a smooth muscle relaxation effect. Here's a smooth muscle contraction effect. Right? So we end up with vasodilation, vasoconstriction, platelet aggregation, antiplatelet aggregation. So we have all of these different prostaglandins that are being produced in different tissues that can cause constriction and dilation of blood vessels, can cause platelets to aggregate, that is, cause clotting or inhibit hormone-like activities. And I mentioned to you when we talked about the prostaglandins early in the course that you probably all, maybe not, but many of you within the last week or so have had a prostaglandin inhibitor. Aspirin, Advil, right? These are prostaglandin inhibitors.
They're anti-inflammatory?
They're anti-inflammatories, but they work. The reason they're anti-inflammatories is because they inhibit prostaglandin. Generally, actually, they inhibit cyclooxygenase. They do have a new drug that's available now that inhibits lipooxygenase that is being used in asthma patients to prevent bronchoconstriction, right? So it's an interesting area of research, these autocrines. All right, so let's leave the endocrine system